Okay. So good morning, everyone, and welcome to all the new residents. I think this is the first lecture that you have for the surgical pathology series. And today our goal will be to talk about some of the issues related to prognostic and predictive factors in breast carcinoma. So the reason this is important is because I just want to establish that when we look at a specimen or a slide or try to render a diagnosis, the only real benefit of that diagnosis, well, I shouldn't say only benefit, but the main benefit of that diagnosis is that we're providing the patient and the clinician with important information that's going to determine the prognosis, which is how the patient's going to do, as well as how they could potentially be treated. So for example, I mean, when you get a biopsy and I know this is really simplistic, but when you get a biopsy and you're trying to make a decision between cancer versus inflammation, for example, yeah, I mean, it's interesting to look at the slide and determine whether it's neoplastic or whether it's inflammatory, but the reality is that the only reason it matters is because the patient is, I mean, obviously the prognosis is very different and the treatment's very different between a neoplastic process and an inflammatory carcinoma, or sorry, an inflammatory process. And the same would be when you're looking at a slide and you're trying to decide, is this adenocarcinoma or melanoma or lymphoma? You could just say OMA and be done with it. But the reason for specifying is because a lymphoma and the types of lymphomas and carcinomas and the subtypes of carcinomas and sarcomas and the subtypes of sarcomas all have implications for how the patient's going to do, and also have implications on how the patient's going to be treated. So in the end, you have to remember that what we're trying to achieve, what's the end goal of what we're trying to achieve in surgical pathology? It's to provide clinically relevant data that is going to be useful for the management of the patient. So we're not trying to provide random data or interesting observations. Those can be beneficial because we use those interesting observations, for example, to generate additional features of prognosis and prediction as far as patients are concerned. But what we present to the world needs to be that which is relevant to the world. And we're not living in a bubble. We have to recognize that we're essentially providing data that's useful to others that are going to be treating the patient. Okay, so with that background, that's the purpose of why I want to talk about the parameter sheet and breast carcinoma. So let's again start by just talking about philosophy of reporting in general. So anytime we get a cancer resection specimen, we're going to stage that. And the idea in the staging is that we want to provide information that is both prognostic and predictive. And first, we should understand, what does that mean? What is prognosis and what is prediction? So in this first slide, I kind of have this here where I say pathologic staging is a compilation of prognostic and predictive factors. And then the prognostic factors are attributes of the tumor that define its behavior, meaning we want to look at different features of the tumor and we want to try to say, okay, based on feature A, it's probably going to behave in this way, or based on feature B, it might behave in another way. And so those are the prognostic factors. They kind of define the behavior of the tumor and hence will then be prognostic for the patient. Are they going to recur? Is it going to spread? Will they survive? So those are all kind of prognostic features that are useful for prognosis. And predictive factors are those factors that are relevant for predicting response to a particular therapy. So for example, when a patient has breast cancer and we do an ER/PR stain, the benefit of that is it will then allow the clinician to know that this tumor is either ER/PR expressing or ER/PR non-expressing. And then based on that, they'll be able to decide whether they want to use, for example, an anti-estrogen therapy. So those are your predictive factors. And we're going to go through the prognostic factors and then the predictive factors. And in between, we're going to touch on the report to show how all of this gets tied together in one final report, which is not particular only to breast cancer, but I'm going to use breast cancer as the dominant example because that's what I do. All right, so I want to just, I know I said this when we started, but I just want to sort of put this in words. When we talk about the parameters that we're going to recite, that we're going to report, those parameters need to be, there are a few features of those parameters that are present before they show up on the reporting form. So they need to be statistically significant, meaning we're not just going to willy-nilly put stuff on the report that it doesn't even have any relevance and is not statistically significant. It can't be, oh, I think this might be bad for the patient, or I think this might be good for the patient. So the parameter form is very tight. It's very restricted in what we're allowed to report, and we need to follow that. And that's pretty much determined by the AJCC guidelines. It needs to be independently valid, which means the studies have shown that it's independently valid. And then, of course, most important, it needs to be clinically relevant. If it's not clinically relevant, who cares? It's interesting, it's nice for studies, and it might eventually lead to something that's clinically relevant, but not on the form. And then, when we apply these criteria, there's actually only a handful of parameters that are going to be useful enough to be included in a staging report. So you could literally do a PubMed search or a search for different criteria of breast cancer, and you'll come up with thousands. But it's interesting, we only use like 5 or 6 on the parameter report, and that's because those in essence are the ones that are statistically significant, independently valid, and clinically relevant. All right, so let's start with the prognostic factors. Why do we care? Or why do we present these? Because they're used for therapeutic decision-making. So in breast cancer, as an example, there's actually 3 categories of patients as far as treatment is concerned. There's patients, and maybe there's actually more nowadays, but just traditionally there's 3. There's going to be patient A who's going to receive no additional adjuvant chemotherapy, or perhaps RT, depending on the circumstance. So there's no adjuvant therapy. That's sort of one possibility. Another possibility is they're going to get standard adjuvant therapy, which would be chemotherapy and then radiotherapy if they haven't had a mastectomy. And then the third would be if they're going to get high-dose selected agents, or perhaps like a boost with RT. And so again, these prognostic factors are important for the clinicians because based on different prognostic factors and data that we present in the report, they're going to decide, is this patient going to get no chemo? Are they going to get standard chemo? Are they going to get a special chemo? Are they going to get RT, no RT, boost RT, etc. So again, this is why these prognostic factors are relevant. All right, so in breast, we have a handful of major prognostic factors, and they're summarized in a few ways, but maybe I'll kind of divide this screen in half. I think I have red, so red on red is not good, but okay. So I'm sorry, I'm gonna divide this screen. Yeah, like I would say maybe we put a line here, and this is represented by the TNM, right? The upper part of the screen, and then these are kind of like a bonus on the bottom. So when we think about prognostic factors, the TNM is a very quick way to remember some of the relevant prognostic factors. So tumor size is going to be important. By the way, when you talk about T, there's kind of 2 main ways, as you're aware. There's the size, which is relevant in certain organs, and then there's the depth of invasion, which is relevant in other organs. And so it depends on really the organ system we're dealing with, and it depends on, sometimes it's both, and I'm going to show you in breast that both are applicable. But anyway, that's size. So size is always a major prognostic factor. And then the N represents regional lymph nodes, and regional lymph nodes is always a major prognostic factor. So these 2 are kind of like your bread and butter. And then M is metastasis, and it is an extremely important prognostic factor, but it usually is not present, particularly in breast, because we tend to catch these cases early before metastasis. And so we don't really see a lot of metastatic cases relative to our overall caseload. However, it would be the most important prognostic factor because if you have metastasis, it's going to be very bad for prognosis. So that's going to be of course, our report's going to contain those things that are going to allow us to generate a final PTNM, okay? And then additionally, you have like a few other factors, of which in breast we kind of have three. We have lymphovascular invasion, which maybe is the least on this list. I probably should have put it sixth. And then we have histologic grade and histologic subtype, which maybe of all of this, the grade is probably going to be the most important. But anyway, we're going to talk about each of these as we move forward. So let me keep going. Okay. So the first of these is tumor size. Tumor size is a prognostic factor for survival. It's also a prognostic factor for spread. And because it's a prognostic factor for spread, it helps to determine whether or not a patient's going to get chemotherapy. I guess survival and spread are kind of interrelated because, it's not the breast cancer that would decrease survival. It's the spread of the breast cancer that's actually decreasing survival. But by spread, I mean outside of the region. So anyway, this is kind of like an old chart. These numbers may not be exact, but the slopes of the lines are. And so if you look at breast cancer, we kind of have three major subdivisions based on size. There's the T1, which is less than 2 centimeters. And then this is further broken down into PT1A, B, and C. Not important for this discussion, but it's present in the AJCC manual. Then there's PT2, which is greater than 2 centimeters up till 5 centimeters, up to and equal to 5 centimeters. And then PT3, which is greater than 5 centimeters. So these would be like our P1, 2, and 3. And the chart on the right, really what I'm just trying to highlight here, it's an old chart. I'm not sure that the numbers exactly are accurate. There may be a difference in survival if you were to look at a particular point on this graph. However, what I'm just trying to highlight here is that, the slopes of these curves vary based on size. And so, this upper curve here represents what happens when it's less than 2 centimeters, in which case the prognosis is fairly good. And then it gets worse and then worse as we increase the tumor size. And so this is the main way by which we gauge the T criteria or the T parameter in the staging. Now, because tumor size is so important, I want to speak a little bit about how we assess the tumor size, because this is going to affect you directly as you're in the gross room. So first of all, there's 2 steps to assessing tumor size. We should measure, when we receive the specimen, we generally will ink the specimen and then put some cuts through the specimen. And if possible, we want to assess the tumor size in a fresh state. So what that means is that we locate the tumor and we take measurements of the tumor while it's fresh. And then we confirm that that's indeed the tumor size that we'd like to report on a gross level after fixation. So sometimes when you fix the tissue, things tend to become a little more apparent. And so we just want to double confirm or reconfirm that size after tissue fixation. And then the next step would be then to confirm microscopically. Now, it's actually, microscopic is more accurate than gross. And that makes sense because a lot of things can cause a gross abnormality in the breast, but it's only when you see it under the microscope and confirm that it's tumor that we're going to be able to assess size. So let me just review how we're going to handle a specimen just as an example. To show you why we do it and how it helps to produce a tumor size. So let's pretend for a moment that this is like a lumpectomy, okay? And for a moment, let's pretend that there is a gross abnormality here. And one of the key things is that we're gonna thinly slice this specimen. So we have this lumpectomy where and as part of the grossing process, we're obviously going to ink, but then we're gonna create all these slices. And as we create these slices, one of the important things for you when you're grossing the specimen to be able to report, let's say this is 1, 3, 5, 7, 9, 11, and I'm just numbering these slices, 13. So it's important for you to say in your gross report, and this is already embedded in the template, but just so you're aware, that I thought that the tumor was present in slice 7 all the way to slice 11. And I thought that the tumor measured in that dimension, I thought that the tumor measured, 3 centimeters. So you're going to provide all 3 dimensions, but it's important for us to be able to say, I saw a gross abnormality it was present in slices 7 through 11, and it measured 3 by 2 by 2, for example, in CM. So that will allow us to be able to correlate, because you'll see when you're sitting in breast sign out, I know when I'm signing out, I'll constantly say, okay, what slice are we in, and what slice was grossly tumor, and are these matching up? And so I regularly will ask you to tell me, like, okay, so what slice are we in? Did that match where the tumor bed was, or the tumor was? And then we'll kind of map along and confirm the size. So that's one important feature of determining size. Another important feature is to get the flanking sections. So for example, if this is a flank, by flanks I mean at the edges. So for example, if this is a flank and this is a flank, it's important to put these in and say, let's put it up here. It's important to put these in and to show that indeed there was no cancer in the, for example, let's say this is medial and this is lateral, in the medial flanks and in the lateral flanks. And so again, that helps me to assess that our gross indeed matches with the microscopic assessment. So for example, if I'm looking at this case, if we're looking at this case together, and you tell me that I grossed it and I thought that there was tumor in slices 7 to 11. However, we look at the slides together, and slice 5 also has tumor, and slice 6 also has tumor, and slice 12 also has tumor. I'm going to come back to you and say, okay, it looks like the tumor was not as apparent as you thought. Can you please go back and give me additional sections of slices 1, 2, 4, 13, 14, et cetera? Because maybe the tumor is bigger than we initially thought. And so maybe instead of a 3 centimeter tumor, we're dealing with a 6 centimeter tumor, which of course would have important implications on how the patient's handled. So, so that's the purpose of putting in the flank sections. And as you review the gross of the breast, you'll understand that, or you'll see that, you know, we ask for these flank sections. So again, if you're thinking through what's going on and you're understanding what you're trying to generate, then it becomes a lot easier. So what's the simple summary here? It is that we need to know how big the invasive carcinoma is. And the only way we can confirm that is to stick these pieces under a microscope and to look at them and say, yes, cancer in this slice and cancer not present in that slice. And so somehow when we sign out, you have to be able to justify in your report how we're going to come up with a final size. And so as you're thinking about how you're going to submit your sections and how you're going to gross the specimen, that's the only thing I care about. I don't care about anything else. I need to just be able to confirm the tumor size. Now, your number one best friend in this entire process is going to be the imaging, because the imaging is going to guide you. It's going to tell you that, for example, if there was an MRI, that there was 6 centimeters of enhancement, particularly non-mass enhancement. And so I'm going to come back to you during the sign out, and if you grossed it, and I'm going to say, how big was it on imaging? And if you tell me, oh, it said 6 centimeters of non-mass-like enhancement, I'm going to say, where is that 6 centimeters? We need to confirm at least 6 centimeters of disease, or we need to confirm some sort of pathologic abnormality that would explain the non-mass enhancement present on the MRI. So, so use the imaging. It will always kind of guide you along. And then to confirm the imaging, you know, you'll put in flank sections at different positions across your gross in order to prove that cancer is not present anywhere other than where the imagers thought it was or where the clinician thought it was. Okay, so essentially, what's the summary of this tumor size? We need to prove microscopically the size of the invasive carcinoma. By the way, one more important thing. Sorry about that. One more important thing is that, you know, you sometimes can have a circumstance where there's like an invasive carcinoma here, and there might be some other imaging abnormalities that extend outside of it. And we need to assess, remember in staging what matters. When we talk about the PT stage, which is the pathologic T stage, what matters is invasive size, not the entire tumor. I mean, for example, if this is DCIS, this is invasion, this is DCIS, this is DCIS, and this entire thing here measures 6 centimeters, but this only measures 1.7 centimeters. We don't care about 6 centimeters. We care about 1.7 centimeters because the staging is based on the invasion. And so that's what's going to drive the clinical decision-making in this patient. Now, why would we care about the 6 centimeters? The main reason we care about the 6 centimeters is because the reason in this case, they would have probably done a mastectomy, because when tumors are greater than 5 centimeters, the patient's going to get a mastectomy. And the reason we care about 6 is because we need to prove 6, because that's why they did the mastectomy. So I'm going to submit us, I don't know, a piece from here, a piece from here, a piece from here. My expectation would be to show DCIS. Maybe I submit a couple blocks, here and here. And then eventually I'm going to continue to submit along the tumor, let's say every half a centimeter or so. And then I'll submit some pieces from here and here in order to prove DCIS. Okay. I'm gonna, I don't know if you're still on, but I can't see the chat box if there's questions, and I can't hear anything either. So I guess we'll see. Okay. Anyway, so that's how we're going to assess tumor size. Now I put a note here. Some of the reasons why it's so important to reassess microscopically. One, because we want to find the exact size of the invasion. And that's really important because for small tumors, the size may even result in no chemotherapy. So for example, if we're trying to decide, a 1 centimeter is a really important number. If the tumor is less than 1 centimeter, those patients often don't get chemotherapy. But if it's greater than 1 centimeter, they're usually going to get chemo. They're not usually, but it's more likely that they'll get chemotherapy. So, the size is going to be important. And also because imaging can underestimate disease. So they may have walked in with an expectation that there's like a 1 centimeter invasive cancer, and we may have a case of lobular carcinoma that may actually extend, for example, 5 centimeters. And of course, that's going to change things for the patient. The next, the other important thing to recognize concerning the PT&M stage is remember this, I told you that there's like a PT, or P1, let's take out the P, we're obviously only talking about pathology. So there's a T1, and then it goes to T3, okay? And that's all based on size, right? And then there is also a PT4. And the PT4 is based on local extension. So the summary of PT4 is as follows. When you think about PT4, it trumps size, and what allows us to go to a PT4 is if there's local invasion deep into the chest wall, which means we're beyond the pec into the actual chest wall, or into the skin. If it goes into the skin and produces a clinical finding in the skin, that would also result in a PT4. So this is what I'm trying to highlight here, the skin and the chest wall. So if the skin or the chest wall is involved, we go to a PT4 classification. When we talk about the chest wall, it means we have to go beyond the pec. That's important because sometimes you'll have an involvement of the pec, but that doesn't matter. That does not increase us to a PT4A. Instead, it needs to involve something like from the chest wall, like the ribs or the intercostal muscles, or etc. The skin is interesting because it usually requires a combination of histologic and pathologic findings. So in order to call a PT4 due to a problem in the skin, you're going to need to see tumor going into skin on the slide, plus some clinical correlate that you would not be able to see without looking at the gross or talking to the clinician. So for example, to get to a PT4B, you need to have ulceration of the skin, which maybe you could see grossly. Probably you could see it on the slide as well, but it's a clinical correlate. You can call up the clinician and say, hey, was the breast ulcerated? And they would say yes. Or you might need to see satellite nodules within the dermis. So you look at the dermis and there's like a nodule, and then another nodule, and another nodule. And you call the clinician and they say, yes, there were satellite nodules. That would give you a PT4, PT4B. A PT4D, easy to remember because it's dermal lymphatics. PT4D involves dermal lymphatics. And that, of course, also requires a clinical correlate because you have to call up the clinician and say, hey, did you see an inflammatory picture? And we call that inflammatory carcinoma. So those are the findings that will result in an upstage beyond size, which basically means that you're now at a PT4, and that has a really changed prognosis and even a changed clinical paradigm of how you're going to treat this patient. Now, I do want to add one thing, which is that skin dimpling, involvement of the dermis, skin dimpling, nipple retraction does not upstage you to PT4. So for example, let's say that that's the surface of the breast, and there's this tumor, and this tumor is right here, you know, up against the skin, and it even goes into the dermis a little bit. So here you've got like dermal involvement. That will not result in a PT4. That will still be based on size. So we'll look at size in that case. Remember, in order to get a PT4 due to involvement of skin, you have to have a clinical correlate. And the clinical correlate is going to be not satellite nodules, ulceration, dermal edema / inflammatory changes. So those are kind of your key changes. And so you generally have to call the clinicians before you can upstage to a PT4. And for those that have been at the breast conference, or who might come to the breast conference, you'll see that anytime we're thinking about a PT4, I won't sign it out. I'll wait for the conference, and I'll speak with the clinician, or we'll speak with the clinician to determine whether we indeed have a correlate. Okay, so now we're moving along. So that was your T. Okay, the next thing is the N. And in order to determine the N, that's their lymph node status. Of course, well, first of all, let's talk about why it's relevant. So generally speaking, if you have involvement of lymph nodes, that's going to result in a worse prognosis. And the larger the number of lymph nodes that are involved, the worse the prognosis will be. And so here you can kind of see this would be 1 to 3 nodes, this would be 4 to 9 nodes, and this would be 10 or more. And that's just sort of mirroring these different PTN classifications. We have a PTN1, a PTN2, and a PTN3. All right, so, and the numbers are written there on the side. Of course, the way by which we do this is we follow the axillary the drainage of the breast. So we do a sentinel node lymph biopsy, a sentinel node biopsy. So of course, you know the principle, which is that the tumors in the breast tend to drain to 1 or 2 or 3 primary nodes, which are called the sentinel nodes. And then beyond that, you kind of have varying echelons of nodes. And so rather than taking out all the lymph nodes in the axilla and creating, you know, edema of the arm as an example, we'll kind of the surgeon will go in and just grab the key node. And if you don't know this yet, you'll become aware very quickly. There is no one sentinel node. It's rare to get one sentinel node in practice. It looks like this, so that you've got the tumor, you inject it with radioactive tracer and blue dye, and then they kind of will find the hot or blue nodes, and they tend to be 3 or 4, and sometimes even up to 7. And so these would be the sentinel nodes, and each of them are treated the same. We will put each one on a slide, look for a tumor, and that will then result in you know, some information that will allow them to determine, number 1, whether they need to resect the rest of the axilla, number 2, whether they need to give chemotherapy, and number 3, whether they need to boost the region when they give RT. So, so this is how we handle the sentinel nodes. I think I missed a slide back here. So just as a reminder, the main nodes that we're going to assess are going to be the axillary nodes. That's pretty much what we receive. Sometimes, very rarely, we'll get an internal mammary node, but all of these nodes are regional. So there's three kind of nodes that are regional that you should be aware of. Number 1, intramammary. Intramammary means a lymph node in the breast. So if there is a lymph node in the breast, that's considered regional, and that falls under the N classification. Number 2, axillary nodes. Those are the ones that we most commonly get. Those are going to be considered regional. And number 3, the internal mammary nodes. Those are also going to be regional. Regional means that we're going to use the N stage. Any other node will be considered distant. And by distant, that means that we're going to move to count that as a metastasis. So for example, if a cervical node is involved, that's going to be metastatic, not regional node. If a contralateral node is involved, that's going to be distant. It's not going to be regional node. And so this is a little bit funny because when you think about involvement of lymph nodes, biologically, it is involvement of regional nodes. So for example, when you have breast cancer in an axillary lymph node, biologically that's metastasis. But in the TNM classification, we don't put that under the M, we put that under the N, because what we mean by M in the TNM classification is that it is a distant metastasis, all right? So biologically metastatic, but distant. So anyway, this is just something to be aware of when we think about the staging of the axilla, okay? Now let's move on. So these are your major, remember I kind of drew a line here. So this is your P, T, N, and then M if a distant site is involved. And then we have a few other important features that I just want to speak of very briefly. One of the things that we report in our parameter sheet is lymphovascular invasion. The reason we report this is because there are studies that show that there's a increased risk of local recurrence within really the first 3 years, let's say. So 3 times increased risk of local recurrence in the first 3 years. And this is particularly important in node negative patients. Look, if the patient's node positive, who cares about lymphovascular invasion? Because obviously it's in the node, so it probably went through the lymphatic. But when you have a node negative patient, it is important to be able to assess lymphovascular invasion because the nodes are negative, but you want to know whether the tumor has this propensity to show up in lymphovascular spaces or not. One of the things about lymphovascular invasion is that there's a real wide range of incidents reported in the literature, anywhere from 5 to 50%. And that's because strict criteria are often not adhered to. The idea here is that, when you have a tumor, let's say this is a slide, okay? One of the things about breast cancer is that it produces these nests of tumor balls. And often, if this is the adjacent stroma, okay, let's call this stroma, often you can get retraction of the tumor away from the stroma, okay? And that'll create like a space. And that space can mimic what appears to be lymphovascular invasion. But really, it's not lymphovascular invasion. It's just a separation of the tumor from the stroma, what we call retraction, making it look like the tumor is actually present in a circular space. And so for this reason, you get some studies report a high incidence of LVI, but when you really follow strict criteria, you probably won't find LVI in more than 15% of cases of invasive ductal carcinoma. So what are those strict criteria? The traditional histologic criteria were actually developed by a famous breast pathologist named Rosen. I don't think he practices anymore, but regardless, his criteria are really good for histologically trying to find LVI. So there's 3 main principles that he would adhere to, and encouraged others to do so as well. Number 1, you shouldn't look for LVI within the tumor itself. Instead, you should look for LVI beyond the edge of the tumor. So usually 1 to 2 millimeters away. So for example, here's the slide, okay? And you've got this tumor here on the slide. So you do not look for LVI here. You don't look for it there because there you're just going to find retraction and get confused. So I don't call LVI if I see it in the middle of the tumor bed unless it's really slapping me in the face. But where you do look for it is out here, like 1 or 2 millimeters outside of the edge of outside of the advancing edge of the tumor. And then what you want to find beyond that, that's criteria 1. Criteria 2 is that the tumor embolus cannot conform to the lymphovascular space. So for example, if this is a lymphovascular space, the tumor should not be the exact same shape of the lymphovascular space. Instead, this is the lymphovascular space. Maybe the tumor is like that. It doesn't match the shape, because if it matches the shape, it's more likely to be that the tumor was just retracting away from stroma. And then number 3 is, so you've got this space, the tumor does not match its shape. And then number 3 is when you look at the edge of the space, you should be able to confirm the presence of endothelial cells along the edge of that lymphatic space. Remember that lymphatic spaces are lined by endothelial cells. Now, sort of taking this one step further, You can also do a stain, an immunohistochemical stain, which you should be aware of, and I'm sure if you looked at these cases before, you can remember. But the stain that we like to use is D240. D240 is a marker of endothelial cells that line lymphatics, and it's a really nice way by which you can highlight lymphatics and the involvement of a lymphovascular space. So sometimes we'll order this stain called D240. That's the most commonly used stain. There are others, but I'm not going to talk about those right now. So anyway, this is a criteria for establishing LVI. Number one, look beyond the edge of the tumor, 1 to 2 millimeters beyond the advancing edge. Number two, the tumor umbilus should not conform to the lymphovascular space in shape. Then number three, you're looking for endothelial cell nuclei, possibly with the help of this stain, which is called D240. Okay. Grade is another important prognostic factor. I would say that, below the line, meaning below the PT, after PT and M, grade is probably most important. It correlates with survival independent of size and lymph node status. So it's really important. And we use a modified system called the SBR grading system because it allows for good inter-observer agreement. That SBR system is based on 3 features. We look at tubule formation, nuclear pleomorphism, and mitotic count. So the way you do each of these is that for tubule formation, it's a low power assessment. I constantly remind people during sign out that we need to do this at low power. And so when we think about a low power assessment, what that means is that we're looking for lumens. We're looking for, at low power, we're looking for circles, like clear lumens. Not sheets of cells, but clearly identified glands. And then we kind of quantify those glands. So if it's the majority of the tumor, then they get a score of 1. If it's 10 to 75%, then they get a score of 2. If it's less, you get a score of 3. Okay. And then the next is going to be nuclear pleomorphism. And so we do that by there's different ways to do that. You can compare the nucleus against a normal luminal nucleus, or you can kind of look at the chromatin, and if it's uniform, or you get visible nucleoli, or the chromatin's vesicular, each of these would result in a different score. And then finally, we count the mitosis. And I want to remind you, when you're signing out breast, you count these mitoses at the edge. So a lot of times when I'm signing out with you, I will say, let's look at the edge and see if how many we can find. We're trying to find as many as we can because that would upstage the tumor. And of course, this gets us a score of 1 to 3 as well. So if this is going to be 1 to 3, this is going to be 1 to 3, and this is going to be 1 to 3, then you can quickly identify that if I summate this down this row, I'm going to have a score anywhere from 3 to 9, right? Because I've got to add up all 3 of those scores. And so the way this works is if I'm at 3 to 5, then I'm going to have grade 1. If I'm at 8 or 9, I'm going to have grade 3. I just remember this as 67 is grade 2. So a 6 or a 7 is 2. Below that is grade 1. Above that is grade 3. So, so that's how we're going to make our SBR grade. Okay, so with all of that as a sort of introduction, I want to just pull up the parameter sheet very briefly. Discard that. Okay, now I'm able to see this chat. All right, so where are we? Here. Okay, great. So this is our parameter sheet that you will become intricately familiar with as you sign out breast, or if you have been signing out breast. It's kind of like that painful thing we have to do with each case. So obviously we say breast pathologic parameters at the top to indicate the parameter sheet, to indicate what parameters we're dealing with. Okay, now I want to just say one thing because everybody messes this up during sign out. We cannot delete anything from this sheet, all right? The hospital reviews our, the hospital reviews whether we're conforming with this sheet and whether we use this sheet and whether we apply all these parameters. And there's actually a governing body in the case of breast that will come and review us every year. And they actually pick up the reports and they make sure that every one of these lines is present with a couple rare exceptions, which I'm going to point out to you. So I know this happens all the time during sign out where someone will come and like, oh, I cleaned up the sheet and I made it more, I just put in the key data. Actually, we cannot delete any line from this sheet. We must answer every one of these parameters and we can say non-applicable, but we must leave these there so that they're clearly identifiable to the reviewers. All right, so we're going to start with procedure and specimen laterality. So you have two choices, and we don't add a third, either excision or total mastectomy. We don't have to worry about, is it a skin-sparing mastectomy? Is it a modified radical mastectomy? Is it a nipple-sparing mastectomy? We don't need that data. We just say excision or total mastectomy, excision being anything less than a mastectomy. And then we say right or left breast. So here, as an example, how would I fill this out? Let's pretend that the patient had a total mastectomy, so I will delete mastectomy. Let's pretend that it's of the left breast, so I will put in left breast. Okay, let's make this red. All right, the next is I have to decide whether I have invasion or in situ as my main tumor in this specimen. So I review the case because we fill out these parameters at the end. So we review the case together, and the case is entirely in situ. So in that case, we will delete this and we will only leave the in situ part, okay? Or I may decide that there is invasion. Once I have invasion, I will delete this. That's why they're both labeled number 1, by the way. I will delete this and I will be left with invasion, all right? So let's quickly look at in situ because I'm gonna delete it. For in situ, we need to know the size. So for example, this is a 6.5 centimeter tumor, and I'll usually say slices 5 through 9. Okay, so that will be my overall size of the tumor based on my microscopic assessment. I will then say, okay, this is DCIS. I will say this is low grade. Focally, I see necrosis, so it's present focally. And calcifications are present, so I will delete absent and leave that as present, all right? So that's how I would handle carcinoma in situ. Let's pretend that there's invasion. So with invasion, I'm gonna enter the tumor size, which is the size of the invasion, not the DCIS. So that might be 3.6 centimeters. Sorry, let's make this red. That might be 3.6 or 3.8 centimeters. I'll then introduce the type in the histologic type, so invasive ductal. Okay, now there are actually over 100 subtypes of breast cancer. I think Aaron's going to teach you all 100. Now, I don't know how many he's going to cover, but Aaron, our former breast fellow, is going to be doing the talk, I think, on the different subtypes of invasive ductal. So you'll learn what you could fill in there later. I'm not going to complicate this discussion today. But of course, then we're going to enter the grade. So for example, let's say that the glands were a 3 and the nuclei were a 2 and the mitotic rate was a 1. So 3 plus 2 plus 1. 6, so that, remember, 67 is grade 2, and the way we write the grade here is in Roman numerals, so now we're going to call that a grade 2, okay? So treatment effect, this depends on whether the patient was treated with neoadjuvant therapy or not. So treatment effect is specific to neoadjuvant therapy. So if the patient was not, I'll say non-applicable. More and more, most of our cases are actually getting treated. I'm not going to talk about this one parameter today. We need to do this on a different day when we're dedicated to talking about how to handle treatment cases. Okay, and here in this case, I get a chance to comment on the DCIS. So if the DCIS is present, I would say present, and I might say this within main mass, spanning. Sorry, let's make this red. Spanning. Oops. Spanning 8 centimeters and forming, I don't know, 10% of the tumor volume. And if it's 8 centimeters, it's probably going to be both with and, so within and away from. So I'll say within and extending away from. So that might be how I would finalize my sort of like characterization of the DCIS. If I happen to have DCIS distant from the main mass, I'll also say that here. Okay, so then I can delete these subheadings here. All right, margins. You'll say free of tumor or positive. So let me very quickly go back and just talk about margins and how we assess those. I know. All right, so the way that you're going to assess margins, let's say here. This is a specimen. What's going on? this. This is a specimen here. So the way the margins are going to be assessed is that we're going to take the specimen, we're going to ink it. We usually ink it 6 colors. Okay. So let's call this medial, lateral, superior, inferior. Okay. In the 2 dimensions that are present on this screen. So each of the colors, each of the dimensions is going to get inked with a color. And then essentially what you're going to do is you're going to put in sections which are going to allow us to determine how far away the tumor is from the margin. So pretend this is the tumor, and you put in, you know, you're kind of slicing along, and you identify the tumor. So when you do your gross, you're going to say, you know, I identified a 3 centimeter tumor in slices 1, 2, 3, and slices 4 through 6, it was present, you know, 1 centimeter from the superior margin, 1.5 centimeters from the medial margin, 2 centimeters from the lateral margin, etc. So that's all embedded in the template. It's important for you to try to grab slices or sections where you think tumor might be coming close to ink. So you might want to grab a section there, a section there, section there, a section there. We usually submit the entire medial and lateral edges to count, you know, as far as those margins are concerned. So anyway, that allows us to assess margin. And of course, margin is important because if the surgeon is going in to remove the cancer, then we want to confirm that the cancer is indeed removed. So in the case of margins, you know, it's either going to be positive or negative. Let's pretend that this is free of tumor. So I do need to say invasive carcinoma is, you know, let's say 6 millimeters from what is the closest margin. Now, why am I reading to you? Because if you're going to be able to answer this question, you need to have known that from the gross, right? You're going to have given me a slide, or you're going to have provided a slide for us that is going to show tumor close to margin, or show that there's no tumor anywhere near the margins. So this is completely based on the gross, because there's no way I can see that, you know, grossly. I'm sorry, it's completely based on the microscopic, which is dependent on a good gross. Same thing with DCIS, okay? So I don't know, DCIS is 5 millimeters from the anterior, okay, closest margin. Now, these margins become important because sometimes if we have close margins, the surgeon will go back and resect those margins. That's something to consider because, you know, it's going to affect how the patient's treated and handled. And so we do want to make sure that we're assessing margins well. Generally speaking, if they have a clean margin on invasive carcinoma, they won't go back. So anything that's technically clean is the way by which they'll handle invasion. DCIS, they're usually looking for something greater than 2 millimeters. If they're greater than 2, they're usually comfortable. But it's really a conversation between us and the clinician. And so if you attend breast conference, you'll know that anytime a margin is close, there's a lengthy discussion between us and the clinical team and the imagers to determine whether they need to go back or not. So it really varies on a case-by-case basis, but this data is exceedingly important to further that conversation. If margins are, let's say this is, for example, 1 millimeter, and this is 1 millimeter, we do want to mention that the additional margins are greater than 2 millimeters away. So we do kind of leave that line there to indicate that beyond the superior and the anterior, everything is greater than 2 millimeters away. Okay, number 3 is blood vessel lymphatic invasion. This is going to be commented on whether it's present or absent. If it's present, we will say where. So for example, if it's absent, we delete these 2 lines, all right? If it's present, we have to say where. So I usually say present in breast parenchyma. Sometimes I might say extensive, or I might say single focus, you know, just to give an idea. If it was present in the dermal lymphatics, I will write that instead. So it might say here, present in dermal lymphatics. Okay, tumor extension. This is the tumor extension that I was talking about that results in a PT4. So we care about this because it's going to result in PT4. So skin means that I have tumor extension into skin. And then if I have that, I'm going to say ulceration, okay, because that would change my stage. Or I might say dermis only. Why would I say dermis only? Because that will not change the stage. Or I might say satellite nodules. Why would I say that? Because that would also change the stage, right? So, I mean, again, who cares about skin until it has an effect on how we're staging? So if it's not present, you know, that's fine. We'll talk about what we'll write there in a second. Okay, nipple, not so important, honestly, but skeletal muscle is, particularly chest wall. And the most important here would be chest wall. So if chest wall is here, you're going to say chest wall. I've never seen a case extending in the chest wall. I mean, sometimes you have a really, really extreme case, but it's exceedingly rare. We don't really see that. Okay, so that's tumor extension. Usually you're going to just put absent. And then the regional lymph nodes. So the regional lymph nodes, you're going to say positive, negative, or not submitted. Positive, negative means that all the nodes that you looked at are negative. Positive means that some of the nodes or all of the nodes that you looked at are positive. And not submitted means that the surgeon did not submit. Not that we did not submit, that the surgeon did not submit the lymph nodes. So here we enter the total number of nodes examined. So if let's say they did a sentinel node biopsy, I would enter 3. And then I'm going to say how many are sentinel, 2, and how many are non-sentinel, 1. What does that mean, sentinel and non-sentinel? Well, normally when they do a sentinel lymph node biopsy, they inject blue dye, they inject radio tracer, and then they'll chase the positive nodes. They'll chase the labeled nodes. And then when they're done, they stick their fingers in the bed and they'll feel around to see whether they can find any other node that feels firm. And if they find any other node that feels firm, they'll grab it and they'll label it as non-sentinel. So anything that might seem abnormal to them when they're removing the sentinel, they'll grab it and call it non-sentinel. And so we do need to assess those nodes as well. If there's a tumor deposit, we need to talk about the size. The size of the largest deposit is important because of the following. Number 1 is if it's greater than 2 millimeters, then it's a true deposit. And we call that a macromet. So greater than 2 is a macromet. If it's 0.2 to 2, then that's called a micromet. And if it's less than 0.2, that's called an ITC, okay? This is important, so I just want to repeat this. If it's greater than 2 millimeters, that's macromet. If it's 0.2 to 2 millimeters, that's micromet. And if it's less than 0.2, that is called an isolated tumor cell cluster, ITC, okay? Isolated tumor cluster. So, so we need to report this because, again, patients get staged differently. For example, if they only have micromet, that's going to be a T1C, sorry, a PTN1MI. MI means micro only, okay, just as an example. Or if it's an ITC, an isolated tumor cell cluster, that doesn't count as a MET, so that's 0. And then we call it I+, meaning they have isolated tumor cells. So you need to comment on the largest deposit. So largest deposit here we would just write the size and we won't include less than 0.2. So you might say, I don't know, 0.5 millimeters. Okay, so let's make this, by the way, okay, so in this count, we will say the total number with macromets would be 0. The total number of micromets is 1, and the isolated tumor cells are 0. So then the way I'll summate this is here I would say positive. Oops, sorry. Here I would say positive, and I would say 1/3. So it looks like that, okay? Extranodal extension refers to the extension of tumor beyond the nodal capsule. And so here I'm going to say present or absent, and then I'm going to comment on the size. This is an important parameter. The reason that this is important is because if we have extranodal extension, number 1, it could drive the resection of the rest of the nodes. So let's say there's a patient, they only got a sentinel node and they're trying to decide whether to take the rest. Sometimes this parameter matters there. And it certainly matters when they're deciding if they're going to give RT to the axilla. If there's extranodal extension present, they're going to boost that RT. So that's important here as well. And then finally, the last parameter here is your treatment effect. And treatment effect is when the patient's been treated with chemo. If they haven't been treated, we simply say non-applicable. But if they have been treated, we'll comment on this. And again, that's beyond the scope of this lecture. So I don't want to touch that today because I've already talked about too many things. So let's quickly just talk about one last thing and we're going to be done. which is that I want to just talk about the nodes, the way the nodes work. Let's go back to PowerPoint for a second. So presentation. Okay, so the way the nodes work is that when you have a node, okay, when you have a node, you need to assess whether the deposit in the lymph node is what we call biologically relevant. Okay, so let me actually take a step back. When you have tumor in a lymph node, that doesn't mean that it's relevant clinically or biologically, actually. For example, tumor could also get there by the surgeon palpating and pressing the tumor, which then causes it to artifactually dislocate and go into the node. So when we think about involvement of node, we have to ask two questions. Is it biologically relevant? And then is it clinically relevant? These are two distinct things. So let's go through some examples. Let's say that there's a big deposit in the node, and I know we're at 9 o'clock, I'm gonna end in 2 minutes. Let's say there's a big deposit in the node, and by big, we've defined that through studies as greater than 2 millimeters. Okay, then that is biologically relevant, which means that we consider that to be biologically relevant, which means that the tumor has a genetic propensity or ability to get to the node. And we also deem that as clinically relevant, which means that that ability of the tumor to get to the node is going to increase the risk of the patient developing distant metastasis. So that's called clinical relevance. So in greater than 2 millimeters, we have both biologic and clinical relevance. Okay, the next option is that we have a deposit, and that deposit is anywhere from 0.2 millimeters up to 2 millimeters. Okay, so in that case, we've got a tiny deposit. So in that case, it is deemed to be biologically relevant, which means that the tumor got there on its own accord, not artifactually. And but it's usually not clinically relevant, meaning tiny deposits in in a lymph node often don't have any effect on the prognosis of the patient and may not even need chemotherapy when they're this size. So that's the second type of lymph node deposit based on size, and that's why we care. And the third is when you have this circumstance where you just have a couple of cells or a few cells, which are all clusters, all less than 0.2 millimeters. And that is considered biologically irrelevant, meaning that it got there artifactually. And it's also considered clinically irrelevant, meaning it's going to have no effect on the patient. So that's why when there's isolated tumor cell clusters, the patient actually gets staged as an N0 because it's not clinically relevant, but they get this I+ designator so that we can study them in the future and we can follow them, okay? And so I+ just means they have isolated tumor cell clusters. So anyway, that's why we provide so much, that's why we provide so much information here in this regional lymph node section, right? Okay, so that's a lot, and I don't want to go too much further because it's an hour, nobody can, and even an hour is too long, honestly. I said I would cover the predictive factors as well. I didn't get to those. We're gonna do that another time. And maybe what I'll do is I'll combine the predictive factors with post-treatment in some future lecture so we can close off the discussion of both predictive factors and treatment, and we can relate that all back to this breast pathologic parameter form. So, so the summary is that we provide clinically relevant data, and that clinically relevant data is going to drive how patients are handled. The easiest way to summate that is to understand the breast pathologic parameter sheet. It will guide us to tell us what we do and don't need to say. And if we just understand how this sheet works and how this data is read by the clinicians, it makes grossing and microscopic assessment so much more relevant and so much more focused, because we know then what we're trying to provide and how it's going to affect how the patients are handled. All right, I'm gonna stop there. I wish I could figure out how I can make this so that I can hear what anyone wanted to say, but don't have that. Okay, I don't know if you're there, Tim, but should I stop there, or how do I say this?
All right, I'm not sure if you can still hear me, but
okay, we're done, and we could just log off, and thank you.